I'm Dr. Sharon Moe from Indiana University School of Medicine, and I'm here today to talk about the kidney, the heart, and bone, and the crosstalk between these organs. So we routinely measure coronary calcification using CT methods, outlining the density of an artery that is similar to the density of bone. This is considered a surrogate for atherosclerotic calcification or atherosclerotic disease, where calcification occurs early in the course of the changes and eventually resulting to plaque vulnerability, rupture, and myocardial infarction. Medial calcification can also occur, and especially in disease states such as CKD and diabetes. These are two pictures of the inferior epigastric artery taken at the time of a kidney transplant. The calcification shown in black is in the medial layer on both of these particular arteries, and the one on the right, it's almost damaging the entire artery. The intima is thickened in the one on my right, and no changes in the intima on the one on the left. The epidemiology of artery-bone crosstalk is that we know there is increased atherosclerosis, cardiac mortality, and vascular calcification with aging. Multiple studies have shown there's also increased bone loss and fractures with aging. But the greater the progression of vascular calcification, the greater the magnitude of bone loss in longitudinal studies. But association does not equal causality. So what information do we have that actually truly shows a link between these organs? Well, this is a very interesting study that was just published by a group in Denmark. They did 5-6 nephrectomies on rats to give them kidney disease, fed them high phosphorus diet, vitamin D, with the result of having diffuse and severe aortic vascular calcification. They then transplanted that calcified aorta into normal rats, group 3 here, and they also transplanted normal aortas into normal rats, group 2. And the result was that the animals that received the calcified aorta transplant had decreased bone density compared to the animals that received a normal aorta transplant. They also took these calcified aortas and normal aortas and they put them in a petri dish, and they saw that they secreted sclerostin. Well, what is sclerostin? It's actually a bone-derived protein, and in the osteocytes in the bone actually make sclerostin, and that sclerostin inhibits osteoblast differentiation and bone formation and stimulates osteoclastic bone resorption. So the net effect of decreased bone formation and increased bone resorption would, of course, mean low bone mass. So in fact, arteries can turn into bone. So if we look at the way normal bone remodels in long bones, we have cartilage cells that proliferate, become hypertrophic, and then lay down a mineral and a matrix to get the calcification. The cell signaling pathways that happen between the resting chondrocyte, the proliferative chondrocyte, and the hypertrophy are shown here, with RUNX2 being a major transcription factor. And in fact, if you knock out RUNX2 in an animal model, the animal fails to form any mineralized bone. Well, taking those same arteries from dialysis patients getting a transplant, we saw one patient's artery that had significant calcification in the medial layer, but also in the intimal layer. Using in situ hybridization for RUNX2 expression, shown in the purple dots, you can see that there is actually a bone transcription factor being expressed near the areas of calcification in both the medial and the artery layers. Vascular smooth muscle cells can indeed differentiate to this osteochondrogenic cell type. So normally these cells sit as a kind of contractile or quiescent cell with increased myocardial expression. Then some insult that increases the intracellular calcium of the cells turns it into a proliferative type cell. With that, there is decreased myocardial expression, and at that point, the cells can further de-differentiate and express this RUNX2 transcription factor and turn into osteochondrocytic-like cells in the vasculature. And they do what bone cells do, they mineralize. So how is it that these vascular smooth muscle cells change to a synthetic cell? Well, many of these traditional risk factors, mediated in part by angiotensin II, can cause this synthetic switch. Then the factors on the right, the so-called non-traditional risk factors, inflammation, AGEs, hyperphosphatemia, can actually upregulate RUNX2 and lead to the osteochondrocytic cells. But the third part, to get to vascular calcification, requires abnormal mineral metabolism and/or reduced calcification inhibitors. So calcium and phosphorus normally combine together, and they will actually continue to grow in the absence of an inhibitor. Pure mineral-mediated changes. So the pro-calcifying factors are, of course, the cellular differentiation and then excess calcium and phosphorus, as we see commonly in CKD. The inhibitors of calcification occur both in bone and in vasculature and keep us from mineralizing in unwanted places, and there are many such inhibitors. One is called fetuin, and this is a circulating inhibitor made in the liver. It is a reverse acute phase reactant. It goes down when there is inflammation. It's like a vacuum cleaner going through your blood, picking up excess calcium and phosphorus conglomerates. In this knockout animal, you see calcification in all of the soft tissues. Matrix GLA protein is specifically expressed in the arteries. Shown in red here is calcification in these knockout animals, where you see deposition of calcium in black along the elastin fibers. In addition to the inhibitors, you can also prevent that conglomeration of calcium and phosphorus from extending, and that's what this novel drug does. In a study in hemodialysis patients where they infused it 3 times weekly, over 1 year, there was a reduction in the progression of coronary calcification in the drug-treated group and a marked reduction in aortic valve progression of calcification. So to summarize the etiology of vascular calcification, in category 1, which is the inflammatory atherosclerotic change, it is located in the intima. In category 2, where we see in chronic kidney disease or diabetes, it's in the media. Genetic changes in these various factors I talked about is also in the media. All of these have gain of activators, loss of inhibitors, and they behave like an osteogenic type process. Importantly, the consequence of this is vascular stiffness. When you have an artery that is not pliable, then the pulse pressure is increased, leading to LVH. In addition, in the inflammatory atherosclerotic lesions, it leads to plaque vulnerability. Thus, vascular calcification can cause multiple cardiac events. Thank you.